Good afternoon. We're very excited that you're joining us for this monthly Stanford Maternal and Child Health Research Institute seminar series. We're very excited today to really put a focus on the Stanford Cancer Institute's research agenda for population science and cancer survivorship group with Melissa Bondy, Lidia Schapira, and Stephanie Smith, who I'll introduce in a second. So this is really the dream team of cancer survivorship that just started at Stanford very recently. What I'd like to do first, though, is to highlight some little housekeeping items. And then next slide, Roxana. So I want to highlight first the next three series, just so you're prepared for them and put them on your agenda. So next month, on January 11th, is Sunny Anand, who will talk about wellness and in the crosshairs of medicine. Very interesting stories from his role now as a sort of wellness expert. On February 1st, we have the CAR T-cell experts in pediatric cancer, Cara Davis, who'll talk about unraveling leukemia in single-cell studies for clinical translation. And then in March, I wanted to point out a wonderful group with Michelle Manja and Juliet Knowles, who'll talk about maladaptive myelination in pediatric epilepsy. These are three amazing proposals and seminars, so please put them on your calendar. Next slide. What I'd like to do then is to just remind you that at the end of this seminar, we'll send you a survey, which I hope you'll fill out, providing any comments or suggestions to help make this seminar series better. And then next slide, just wanted to then highlight the education committee who work hard to actually bring you these seminar series. If you'd like to join the committee, please let us know. Or if you have ideas for the committee, also let us know as well. And in particular, wanted to point out that our annual MCHRI seminar annual symposium, which we just finished actually a couple weeks ago, will be on Thursday, October 28th. So mark that as well. But for today, I really wanted to highlight the cancer survivorship group at Stanford and three amazing participants. Melissa Bondy, the chair and professor of epidemiology in the newly formed Epidemiology and Population Health Department, associate director for population science and cancer, Stanford Cancer Institute, and the co-director for the population health sciences. She's really recently recruited from Baylor, a world expert in population sciences, who will sort of lead off today and focus a lot on health disparities and current studies in actually glioma and epidemiology, followed by Stephanie Smith, who's an instructor of pediatric hem-onc at Lucy Packard Children's Hospital. Again, who plays a big role, has published enormous on cancer survivorship. And then finally, Lidia Schapira, who's really the director of cancer survivorship program, who will finish up. So because to give them as much time as possible, I just wanted to introduce Melissa Bondy. So Melissa, thanks so much for joining us. I look forward to the group presentation.
Great. Thank you so much for that wonderful introduction. I really appreciate this. So what I'm going to do is start this program off, this session, and talk a little bit about why I was brought here. And one of my jobs is to head up into is this population sciences program within the Stanford Cancer Institute. And we have a great program. We want to even get greater. And part of this seminar is for us to tell you a little bit about the program, one aspect of it, which is survivorship. And if anybody is doing any work in cancer, especially in population sciences, we'd be delighted to have you as a member. And you just have to apply through the Cancer Center and tell them you're interested in population sciences. And we'd really like to have you think about joining. So I'd like to introduce three of our program leaders. Esther John is a professor of epidemiology and population health, and she is a cancer epidemiologist. Allison Curian is professor of medicine, and she has a joint appointment in epidemiology and population health. And she is a medical oncologist slash epidemiologist slash geneticist. She's really doing some amazing work, and I'll just give you a little bit of insight into some of that of her work. And Marcia Stefanik is professor of medicine, obstetrics, and gynecology, and also has a courtesy appointment in epidemiology and population health. And she has been doing tremendous work with the Women's Health Initiative, interventions, and that's kind of how she's brought together. We brought together the three aims of the population sciences program. Next slide, please. So just to give you a little bit of who the program members are and what departments they're from. So we have 37 members in our program, and they include both full members who have funding. They can have any type of NIH or any type of funding that could be from philanthropy, could be from other types of organizations and things like that. So that makes them a full member. Or we have clinical members who are doing clinical research or clinical trials or participating in programs across the within the Cancer Institute or other areas of research. Just this last year, the NCI really likes metrics. And so when we go in for our renewal, which is coming up in the next couple of months, the things that show them whether or not we have good programmatic intra and interprogrammatic collaborations. They look at the metrics by how we publish together. And in 2019, we've had modest intra-programmatic collaboration, but we've had a lot of changes in our membership, and we're just now building the program and having more intra-programmatic collaboration. But we're very team science oriented, and many of us, at least 72% of our publications are multi-institutional, and 12% are published in high impact publications with an impact factor greater than 10. You can see that we've increased our support, and this is from 2019, and you can see that we have about $8.6 million. We've gone up about $8.6 million since 2018. So we have $18.5 million of peer-reviewed funding. So we've done pretty well and continue to do better. Next slide. So these are our goals and our aims. So our overall goal for our program is focusing on priority cancers that are identified through our catchment area and looking at the cancers that are affecting our catchment area, which is 9 counties surrounding Santa Clara County. So the goal is to reduce the cancer burden across the cancer continuum through multidisciplinary, hypothesis-driven research on cancer etiology, screening, treatment, and outcomes that will impact the public health by guiding clinical practice and health policy. So you can see the continuum goes from pre-diagnostic risk, early detection and prevention, diagnosis, treatment, survivorship, and late effects. And this is what we're going to spend our time talking about the rest of this session. And then mortality. So aim 1 is etiology, risk prediction, and screening. And it's an observational types of research that our members are doing. Aim 2 is treatment and outcomes, which are these boxes right here with treatment, survivorship, and mortality, and how we can reduce that and make an impact in reducing late effects, mortality, and improving treatment. Aim 3 is interventional research, which the aim is to reduce cancer risk and adverse outcomes through interventions. Next slide, please. So I'm just going to give a few a couple of highlights for some of the work that our members are doing. So this is work that Esther, John, and Allison Curian have been doing in breast cancer genetics and minorities. And the goal is to identify molecular risk factors for breast cancer in racial and ethnic minority populations. And they have used an incredible study, Northern California Breast Cancer Family Registry, that Dr. John started some years ago, and 75% of the participants are minorities. And this includes, it's a large consortium study across the United States and outside of the US and international groups of families. So they have done studies in Latinas, African Americans, and Asians. They've been doing genetic risk scores, looking at SNPs and GWAS related to these three populations. And so what they've identified is specific polygenic risk score that predicts breast cancer in Latinas. And it's similar as this has been similar as in Asian American, I'm sorry, European Americans. We've also looked at other panel-based gene platforms. There was a study, the carrier study, which was the first study in African Americans, and these genes they're currently testing these to evaluate the validity in African American women. So in terms of the impact, they've identified that these genetic risk scores better predict breast cancer in terms of screening and prevention in diverse populations. And this study's been funded through a U01 mechanism from the National Cancer Institute. And they have been publishing data from these particular populations in high impact journals. Next slide, please. And so there's been an incredible, I'm just going to run through because we don't have a whole lot of time, but one of the things about our program is that we want to make an impact in the catchment area of our cancer center. And so some of these cancers that are important in our catchment area are breast cancer. And these are some of the research areas that people have been working on. This is some of the work that Dr. John's been doing. She's been working in pathoepidemiology and contralateral breast cancer genetics and African ancestry populations. And she's also been looking at environmental factors, pHs, and puberty in girls who are increased risk of developing breast cancer. And this is some of the work that she's been doing. Dr. Kurian has been doing an incredible amount of work in breast cancer and genetic testing. And she has several large studies, one called the Georgia, California Gene Link Study, where they're taking data from many of these companies that have been doing high-risk genetic testing and these arrays, and they're matching them up with the SEER registries in both Georgia and California to look at how these genes might identify and predict people that are at risk of developing breast cancer. And we also have other work in breast cancer that Dr. Palesh is doing, and this is related to breast cancer survivorship and neurocognitive outcomes, and also work that she's doing in insomnia that during chemotherapy, and these are survivorship studies. Dr. Linos has been working in skin cancer, and these are some of the other areas of research in physical activity, obesity, and diet that are being done by other members, Dr. Goldman Roses, Dr. Abby King, who runs an incredible research program in citizen science to promote sustainability, sustained physical activity in low-income communities. Tom Robinson, who I saw as a member of the committee, has been doing also incredible research in family-based groups and behavioral weight control programs for children with obesity. And Dr. Stefanik and Dr. Abby King have been working with the Women's Health Initiative, also in trying to have interventions for more healthy physical activity in this randomized clinical trials that they're working through. Next slide. So this is just a little bit more information on the Gene Link study that I just mentioned, and these are the different testing labs that I talked about. And so what they're trying to do is to look at gaps and disparities in testing use and results, and how they can identify these genes and predicting survivorship in association with these test results. So the study has incredible impact because it really can inform clinical practice and guidelines about genetic testing, utilization, and treatment based on genetic testing results. This is her research, their research, because it's a large group, has been published in many in high impact journals such as JAMA, the NJCO, which were really she's in actually the process of recompeting this grant and expanding it into other SEER registry areas. Next slide. So I see my slides are a little bit out of order because this population science research should have been with the other one. And we are also doing a lot of work in tobacco, e-cigarettes, and marijuana use and how that impacts our populations. Dr. Bonnie Halpern-Felsher has been doing a lot of work integrating health, behavioral, and economic research on some of these emerging tobacco research. She's had an impact in affecting policy throughout California and other states with changing practices, especially with children, and making an impact in policy. Dr. Hendrickson is also working in tobacco, as well as Jody Prochaska, and Dr. Spiegel has developed an interesting Stop Smoking Alexa app where people can learn to do self-hypnosis for about 10, it's in 10 minutes, and they can help to reduce their urges for smoking and hoping to actually quit. Next slide. So what are our future plans? So as we go into our renewal for this, for the Cancer Center renewal, we really are trying to develop new programs that are going to have impact in our community, as well as making an impact from Stanford and our Cancer Institute. And one of the things that both Lydia and Steph are going to talk about is our cancer survivorship program, where we are now and how we're going to expand across the life course from pediatrics, AYA, adults, and geriatrics. And with the arrival of Dr. Tanya Gruber, who's the chief of pediatric oncology, this is really a priority as we move into the next aspect of our research. So we've also planned developing a survivorship cohort. Unfortunately, it didn't get funded, but we're getting ready to put it back in once we receive our comments on this particular grant. And it was a very unique study of cancer survivorship in sexual, gender, and racial and ethnic minorities. We're also planning to develop a shared biospecimen resource, and with that, working with SHC on sequencing patients who are walking in the door to be able to integrate that into our cancer survivorship program so that we can identify genes that might put individuals at increased risk of developing recurrences, or ways that we might be able to identify polygenic risk scores that can help improve their survival and part of our research efforts. So our goal also is strengthening collaborations with the Center for Population Health Sciences, where we have large databases that can be used for all kinds of research, looking at social disparities and social determinants of health. We're working with people in biomedical data sciences and risk modeling. And we're hoping that we could do a little bit more work, excuse me, with the baseline study, which includes other aspects of cancer imaging, and working with the early detection program as part of the Stanford Cancer Institute, and also with the VA and the Stanford Center for Longevity. Next slide. So the next part of this, I'm going to stop talking and pass this on to Steph Smith, and that she's going to talk a little bit more about some of the programs and things that they're working on more specifically. But if anybody's interested to hear more, or to talk about membership into the population sciences program, please get in touch with me, and I'm happy to answer questions after the end of this lecture. Thank you.
And Lydia is actually going to start us off in this section.
So thank you so much, Melissa. I'm so excited to be here today with all of you. So let me start by defining the population that we're talking about and giving you an idea of the magnitude of the challenge and the opportunities that we have for research and for improving health outcomes. If you look here, this gives you a very lovely visual representation of the number of cancer survivors. And we define cancer survivor as anybody following a diagnosis of cancer and for the rest of their life. So back in 1975, we had in the US approximately 3.5 million. And today we have about 17 million in the US. And this number is growing, as you see here. Globally, we have more than 40 million, approximately 43 million cancer survivors. And I'm going to just introduce the idea that some of those are living with some disability related to either their cancer treatment or other associated factors. About 7 million out of those 43 million are living with some disability. So our work and our challenges in thinking about research for cancer survivors does not stop with the end of treatment. We are interested in quality of life and in all of the domains that determine what we globally call health outcomes. If you take a closer look at this graph, you'll also see that the population that is younger, here defined as less than 50 years, is growing steadily, but the population that is older is growing at an even faster pace. And one of the challenges that we face is that this silver tsunami in survivorship is a result of earlier detection in adults, better treatments, and improved supportive care, that the numbers of these cancer survivors really require us to rethink the workforce that will look after them. So for pediatric cancers, much of the success and improvement is due to advances in supportive care and treatment. For the adult and older cancer survivors, the increasing number of survivors, the growth of this population is due to more factors, including detection and treatment, and it presents us all with an opportunity to study their needs and also to think about care delivery. Next slide, please. Let me give you a few examples. Up here, we see a caricature or representation of an older man. We'll call him Bob. Let's say Bob was successfully treated and cured of an HPV positive head and neck cancer, which is an important cancer that is rising and can be cured and accounts for a larger growing number of survivors. Now, Bob is now unemployed because he now has peripheral neuropathy as a result of his cancer treatment. Peripheral neuropathy is a very common complication of cancer treatment. Next, please. Typically occurs as somebody is getting treated. Unfortunately, there's no lab test or smart question we can ask to identify those who are at risk for neuropathy. And so once it settles in, it runs its course. It doesn't always resolve completely and may lead to permanent disabilities and discomfort. Now, Bob also has some cognitive impairment and depression as a result of his treatment. Depression is quite common in head and neck cancer survivors, and even the risk of suicide is increased. So this just to show you that in the certainly in the world of adult oncology, we're constantly thinking about the long-term impact of treatment. And I know that with our colleagues in pediatric oncology, front and foremost is also to think about de-escalation of therapies, meaning how we can possibly reduce the treatment in order to minimize the toxic exposures that can lead to long-term disabling effects, as in Bob's case. Now, in the lower corner here, we see a portrait or a representation of a young woman. I'm going to call her Amelia. And Amelia is now 32, and she has a history of Hodgkin lymphoma. We'll say she was treated at age 17. She was treated successfully, but now Amelia comes into one of our primary care practices, and she knows, and we need to address the fact that her prior treatment with radiation has increased her risk of breast cancer. So she is now she now has the same risk as a young woman who carries a mutation, say, in her BRCA gene. So she needs to start very early screening, and this needs to be addressed. In addition, she may be at risk for cardiovascular disease. So Amelia here represents the important concept of late effects, meaning the problems, the medical problems and comorbidities that may arise many years after completion, successful completion of cancer treatment as a result of the toxic exposures. So in thinking about care of cancer survivors, research, and possible interventions, long-term effects of cancer treatments and late effects of cancer treatments are very important parts of our agenda. Steph, I'll turn it back to you.
Yeah. So thank you, Lidia, and thank you all. So as we think about childhood cancer survivors, I think it's really important to take a step back and realize the incredible progress that we've made over the past 50 years. As you can see in these graphs, patients who were diagnosed with acute lymphoblastic leukemia or Hodgkin lymphoma back in the 1940s to 1960s really had almost zero chance of long-term survival. And you can see these drastic improvements in 5-year survival outcomes over the years since that really were a result of the introduction of multi-agent chemotherapy and radiation therapy. And this was all research that was made possible because the vast majority of children with cancer have been and continue to be treated on clinical trials, which are collaborative, multi-institutional, national, and sometimes international studies that have really enabled this incredible progress, such that today, for all comers, if you consider all pediatric cancer patients who are diagnosed today, the 5-year overall survival rate is actually greater than 85%. And this is quite remarkable and certainly something to celebrate. But unfortunately, the success is tempered by the fact that, and really the reality that exactly as Lidia has mentioned, cancer treatment at a young age places cancer survivors at risk for chronic health complications later on, which may lead to disability. These include things like chronic health conditions that you might see in the general population, as well as secondary cancers. And we can see that even though there have been incredible improvements, even for cancer survivors who were treated as recently as the 1990s with combination chemotherapy and radiation therapy, their projected lifespan, total life expectancy, is still on average about 15 years shorter than their peers who are not treated for cancer at a young age. So clearly there's a lot more for us to do. As we think about really the recognition that childhood cancer survivors as they age were at increased risk of developing health problems at a far greater incidence than their non-cancer treated peers, really there was this recognition that through large collaborative clinical research studies, people were able to actually directly link therapeutic exposures with the risk for specific late effects. And much of this research came from these large epidemiologic, retrospective, and prospective cohort studies. One example that I'll show here came from the Childhood Cancer Survivor Study, or the CCSS, which is, as I mentioned, a large cohort study that has followed adult survivors of childhood cancer for many years. And in this analysis, we see that at a mean age of only 26 years, 62% of survivors had a chronic health condition that was not their primary cancer. And at 30 years after their initial cancer diagnosis, nearly 3/4 had any chronic health condition, and 42% had a severe, disabling, or life-threatening condition, or had actually died from a chronic condition that was not their cancer. Shortly after the study was published about 15 years ago, I worked with Dr. Effinger as a research assistant. And while I was working with him, I was able to see firsthand how epidemiologic research can directly impact patients, learning from him in his clinic for adult survivors of childhood cancer, exactly how we can actually apply these population-based research findings to the care of an individual. One of the important principles that a lot of this research has shown is that childhood cancer survivors, as they grow, have an increased risk of premature or accelerated aging. And what I mean by that is, I think, illustrated really well by this research finding here. So this is a population of adult survivors of childhood cancer in the St. Jude Life cohort study. At the time of the study, they were a mean age of 33 years only. And yet, the same proportion, roughly the same proportion of patients who were adult survivors of childhood cancer met criteria for frailty as an older adult population. These were individuals between the ages of 65 and 100. And frailty is something we typically think of, we associate that with aging, right, with geriatric medicine. But what we're seeing is that these young survivors are actually meeting criteria really at the same frequency as older adults. And so the question is why? That's where the research is centering right now, to really try to understand what's setting up these individuals for such severe complications, and ultimately how can we intervene and what can we do to treat. And I think this illustrates really well how important it is to take that life course perspective, where we think about the number of the great successes in treating pediatric cancer patients who are diagnosed in childhood and adolescence, but unfortunately the recognition that that results in young adults who have chronic conditions, and ultimately an older adult population or an aging population of cancer survivors who are at increased risk of premature aging and frailty and many complications that we see in our older adults. So the next thing that we'll take a little bit of a segue to talk about basically a case study of where do we take this research now. So we know how important it was for earlier studies to map the specific links between therapeutic exposures and specific risks of late effects. And one of the questions that many of us who are in the field are starting to ask is, how do we better capture the toxicities and the long-term and late effects of new agents so that we can eventually use that knowledge, just as we have the knowledge about the long-term toxicities of chemotherapy and radiotherapy, to improve our upfront treatments now that our treatment paradigms are changing so much in pediatric oncology and medical oncology. And so we'll take this deeper dive into an area of investigation that was funded by the Maternal Child Health Research Institute through a clinical MD training grant from 2018 to 2020. As many of you know, and as I've already alluded to, the landscape of pediatric cancer treatment is rapidly changing. We've had the introduction of targeted biologic therapies, immunotherapies, and cellular gene therapies at an incredible pace. And I'm sure in these, in these seminars, you've seen many of these. The question that I'd like us all to think about today is, what are the long-term and late effects? At this point, they're not well understood. And in truth, that's partly because these therapies are relatively new. We have relatively short follow-up for many of the patients who have been treated in this way. We don't yet know if they'll result in durable survival, although we hope that they will. And in some cases, we know that they do, in at least the short to medium term. And as we start to think about linking the research and understanding how long-term and late effects really come to play, we know how important it is to first describe the late effects before any of the more advanced work, which is to say, really understanding risk factors, how to prevent complications, and how to modify upfront treatments. First, at the base, we have to describe, we have to understand what we're looking for. And so that's where we'll start right now. I'd like to tell you a little bit about the use of targeted therapies in Philadelphia chromosome positive leukemias. Some of you may know that BCR-ABL tyrosine kinase inhibitors, or TKIs, are a really great example of a rationally designed therapeutic that was designed specifically to inhibit the oncogene that drives the driver mutation in CML, or chronic myeloid leukemia. And this has drastically changed the treatment paradigm for patients with CML. In the past, patients with CML required multi-agent chemotherapy and a bone marrow transplant for any chance of a cure. And today, in newly diagnosed patients with CML, we can actually tell them the treatment is a pill that you take every day. It's once a day or twice a day, depending on the medication. It's fairly non-toxic, at least in the short term, and we think in the long term. And most people will never require chemotherapy or a transplant, although a small minority do, but again, that's caveated. The catch is that these patients will take this oral pill indefinitely at this point. There are some studies that are investigating whether at some point it would be feasible to stop the tyrosine kinase inhibitor and complete treatment. But at this point, the verdict is still out in pediatrics. And so the expectation is that patients will be on this medication indefinitely and really for the rest of their life. And the other corollary to look at is Ph positive acute lymphoblastic leukemia patients, or ALL patients. And for them, they receive a combination of the targeted therapy, the TKI, plus a backbone of multi-agent chemotherapy that's shown to be effective in high-risk leukemias. So the main questions that emerge as we think about these topics are, first, what are the potential long-term and late effects of TKIs? And secondarily, and this is really a clinically relevant one for those of us who are clinicians wondering, how do we monitor these patients? The question is, well, what surveillance for potential late effects is appropriate in the clinical setting, especially in the absence of a lot of information long-term? So we're in an area of uncertainty. So to start to answer these questions, we first started by looking at what we know, which is what's happened here at Stanford. So we started the Stanford Pediatric Oncology Targeted Therapy, or SPOT cohort, which was a retrospective study of pediatric and adolescent young adult patients who were treated here at Stanford for CML or Ph-positive ALL with a TKI. And I won't go through too much of the details of the patients treated here, but we'll use this as a jumping off place to tell you about some of the key observations that ultimately led to subsequent collaborations, and that's some of the research that we'll present today. One of the most important observations was that there was widely variable medical surveillance for potential long-term toxicities of TKIs. And we'll talk through exactly what that means. But with this, the question that arose is, what's happening outside of Stanford? So the first thing that we did was we wanted to answer the question, how do pediatric oncologists actually think about the risk of these medications? And what do they do in the clinic to monitor their patients? So this was a survey that we developed in collaboration with the Children's Oncology Group CML Working Group. And the aim of the survey was to evaluate how pediatric oncologists perceive the risk of tyrosine kinase inhibitors, and what do they do to actually look for potential late effects in their patients who are taking tyrosine kinase inhibitors for CML. So again, these are patients who have single agent exposure. They're taking an oral TKI for years and years on end. And in total, 118 respondents participated in the survey. And we'll talk through what some of those, some of their perceptions were. So first, if we think about the risk of late effects, we first asked them to consider the overall risk of anyone who's been exposed to a tyrosine kinase inhibitor for more than 5 years. And we wanted them to think separately about the pediatric patients. And here, I mean patients who are prepubertal. So think about anyone from the ages of really infancy up through 12, 13 or so, versus their adolescent young adult patients. So anyone who's in the pubertal time period and after. And those are shown in gray in the charts that we'll show. You can see in general, most oncologists thought that there was low to moderate risk overall of tyrosine kinase inhibitors. And there was about 10 to 20% who really said outright, there's insufficient data. There's no way that I can estimate that risk. I think that's interesting in and of itself. And then we started to look at, what do you think the risk is of individual potential toxicities? So I've shown a few here. The first is growth abnormalities, and then thyroid abnormalities or cardiac disease. And what you can see as you start to look at these is that for the most part, the oncologists thought that there was a relatively low risk of having, for example, thyroid problems or cardiac problems emerge while patients were receiving TKI treatment. The exception here is in growth, where you can see that actually quite a larger number of oncologists thought that their pediatric prepubertal patients were at least at moderate risk of having growth problems as they age on TKIs. And this actually reflects what's in the literature, which is that there's the most data that exists really in this field is a few relatively small studies, but convincing studies showing that pediatric prepubertal patients who are on tyrosine kinase inhibitors for CML are at risk of having linear growth delays during the time of their treatment. So we can see that at least some of the respondents were familiar with this and had interpreted that as meaning that they're at moderate to high risk of having growth problems. Then we said, well, okay, knowing your risk perception is important, but how do you actually screen your patients? What monitoring do you do for them when they're on TKI treatment? And we saw, this is just a snapshot of a few of the responses, but we saw that nearly all monitored growth, which for any oncologist in the room, that makes sense because we actually have patients get their height and weight tested at every clinic visit regardless. So that's kind of a no-brainer. And then in terms of thyroid or cardiac function, we saw that about 50% to 2/3 or so reported monitoring tests for both cardiac function and thyroid function routinely, even in asymptomatic patients. I think this is a little bit interesting given that we see that most people thought that they were relatively low risk, and yet they were still doing some amount of testing regardless. So as we look at the results of this study, we can see that these were experienced pediatric oncologists who responded. More than 3/4 were in practice for more than 10 years. And yet they reported really variable perceptions of the risk of late effects of tyrosine kinase inhibitors, as well as variable reported practices of how they monitor their patients who are on TKIs. There was also a low proportion, only 22%, who reported that the risk of long-term effects of TKIs influences how they choose among different TKIs to prescribe their patients and newly diagnosed patients. And this is important because there are now at least 2 TKIs that are approved for upfront treatment in newly diagnosed pediatric patients with CML, a third on the way, and many more to come. And we think at least that their efficacy is relatively similar. So then the question is, well, how do you choose? And is there anything that you can learn about the long-term or late toxicity profile that may impact your choice up front? And at least from this survey right now, we know that really only a minority are starting to consider long-term risks when they're choosing among upfront TKIs. So all of this is gathering the evidence that suggests that we need more studies to systematically evaluate long-term risks and refine surveillance recommendations in this population. The next question that we asked was, well, what do people actually do in practice? So we know what pediatric oncologists tell us that they do in terms of surveillance, and we have a sense for what their risk perceptions are in terms of the risk of late effects of TKI. But then we wanted to understand what was happening in the real world. And so this was a collaborative study where we merged our SPOT cohort, so that was the Stanford sample, with a similar institutional study from collaborators at MCHRI. And we basically evaluated real-world surveillance for potential cardiac and endocrine late effects of TKIs. Our main outcomes were getting at patterns of surveillance, so echocardiograms, EKGs, thyroid function tests, and some other more specific endocrine testing over the course of a patient's treatment with TKIs for either CML or Ph-positive ALL. And some of the key findings we'll walk through here. So about half of the patients who are on chronic TKIs for CML had any cardiac or endocrine surveillance during the course of their TKI treatment. We saw that there was wide variability from one individual to the other over the course of their duration of therapy. And what that means is some people had absolutely no surveillance for potential cardiac or endocrine toxicities over the course of many years of TKI, whereas others had frequent testing. They may have had even yearly testing with things like echocardiograms and EKGs, and still others just had one test over the course of, say, 6 years of treatment. So it was really hard to pick up, to identify any clear trend, except again to say that there was a lot of variability in what people do. When we looked at patients with Ph-positive ALL, we saw that they in general had more late effect surveillance than patients with CML, which really makes sense and reflects the chemotherapy-based guidelines, which would suggest that because of receiving certain multi-agent chemotherapies, they're at increased risk of late toxicities, and they had certain screening as a result likely of that. So again, this study, which looked again at real-world surveillance between MCHRI and Stanford, showed that there was incredible variability that again highlights the need for larger studies, longer follow-up, and ultimately standardized surveillance recommendations, so that at least from institution to institution, we're screening in the same way. And that's really the only way that we'll be able to ultimately improve our ability to capture or identify potential long-term toxicities of these new agents. So as we look to the future, what's ahead for new agents in the fields of long-term or late effects? I think there's clearly both challenges and opportunities. And we'll talk through what some of those are. It's evident that higher quality evidence is needed. The Children's Oncology Group Childhood Survivorship Guidelines have for the first time established a new task force specifically designed to evaluate the late toxicities of new agents. And so this is a really good sign because it means that experts in survivorship agree that this is an important area of investigation. Some of the challenges that you can already see from this data is that these are rare diseases, small numbers, and small numbers are made even smaller when you start to identify individual biologic factors that subdivide our populations even more. There are many therapies, and there's limited follow-up at this point, limited follow-up time. These challenges ultimately will translate into more opportunities. So that means opportunities to explore mechanisms of toxicities, to identify emerging signals for toxicities, and ultimately to collaborate more broadly to start to build infrastructure to identify earlier signals for toxicity, mostly and really entirely with the goal to inform clinical care and improve outcomes for our patients. And with that, we'll transition to talk a little bit about survivorship research at Stanford. So the first thing that I'd like to do is to tell you how we think about survivorship research. First and foremost, our research centers around our patients, their caregivers, their parents in the case of pediatric oncology, and their communities. So really, when we think about our research questions, all of the questions that we ask are deeply rooted in the needs of the community. Cancer survivorship research, as I'm sure you've seen today, and I hope you'll start to understand as we talk more about these issues, it really brings together individuals and teams from many disciplines, both across campus and outside of our campus as well. So at least represented here in our group are individuals from psychiatry and behavioral health, primary care and population health, medical and pediatric oncology, the adolescent and young adult cancer program, and the Stanford Center for Longevity. What unites our efforts is our emphasis on population health, professional education, clinical innovations, advocacy and policy changes that help our patients, patient-clinician communication, and patient self-management. These are all key aspects of our research as we work toward our ultimate goal to improve health outcomes for our patients and to improve health outcomes for their families and for their communities. And so in the next segment, we'll show a few examples of some of these collaborations and some of the work that's being done at a programmatic level. The first example I'd like to give is an example of professional education. This is a course that we developed with collaborators at the medical school, instructional designers in the group known as EdTech. And what we did was we developed an online case-based animated course that's freely available for healthcare providers and clinicians really all over. And our goal with this course, and you may recognize a few of the characters from earlier in the talk. So here's Amelia and here's Bob. If you have the time and interest to take the course, you'll learn about Seema and Richard as well, and their primary care doc, Dr. Kim, who you'll hear a little bit about in a couple of slides. But the goal of this course is to be practical, to help primary care doctors and clinicians understand how they can integrate certain aspects of survivorship care into a primary care practice and other general practices as well.
So we actually are, we are doing this, we are testing this. We have the good fortune of having a primary care physician. Next slide, please.
Sorry about that.
I
don't know how it went back.
No problem. So Dr. Kim is a primary care physician, and what we've done at Stanford is we have incorporated survivorship experts within the clinical care programs at the Cancer Center, but for adults, we also have a primary care physician who has a consultative model for providing survivorship consultation to patients with the idea of being able to translate the care and package it in such a way that it's portable for the patient and understandable by the primary care in the community. Dr. Kim's practice also serves as a hub for research and education, and it serves also to us to bring the questions from her practice over to the research team as she uncovers some of these unmet needs expressed by the patients. Dr. Kim is also a resource, acts as a resource to her peers through formal and informal consultations. And I'm pleased to say that we'll expand her practice with the addition of another clinician who will also be able to provide primary care and survivorship care starting in July. Next slide, please. Another example is Dr. Catherine Benedict, who is both a clinical and a research psychologist who started a clinical service that addresses one of the unmet needs for the population of adult cancer survivors at Stanford, and that is sexual health for women who were treated for cancer. Dr. Benedict also brings a wealth of expertise and has an important research portfolio in the area of family building after cancer. She's interested both in oncofertility, especially for young women, as well as sexual health. Next slide, please.
Lydia, 2 minutes.
You're close to wrapping up. So we'd also like to introduce the research of Dr. Lauren Heathcote, who is an experimental psychologist and founder of the Pediatric Effective Research and Oncology team, or the PARROT team. And she and her team have developed a series of studies investigating the relationship between bodily symptoms and psychosocial outcomes, primarily in adolescent and young adult cancer survivors, specifically looking at fear of cancer recurrence and quality of life. So the first of these studies involves qualitative interviews and surveys. The second, a mobile app that's designed to capture survivors' real-time experiences and symptoms around follow-up visits. And the third, an international survey that's being developed to understand how pediatric oncologists discuss symptom monitoring with their off-treatment patients, and in what ways that may impact how patients perceive their symptoms and ultimately inform our practice with respect to how we actually counsel patients, so as to ultimately be able to decrease things like fear of cancer recurrence and adverse psychosocial outcomes. We'd also like to briefly tell you about a new clinical pilot clinic that we've developed in collaboration with the Stanford AYA Cancer Program, collaborators in hematology at Stanford Cancer Institute, as well as pediatric oncology. This is a pilot clinic specifically for adolescent young adult survivors of leukemia and stem cell transplant, with an emphasis on transitioning them from pediatric to adult-focused survivorship care, knowing that this is an area of unmet need and really where a lot of survivors can fall off the map and be lost to follow-up. Exactly as the time, as you remember from before, where the risk of late effects is increasing as they age, they become less likely to show up for their follow-up visits. And so our goal in clinical practice with these patients is really to focus on improving their knowledge of their past treatment, support them through many of the AYA-specific issues that arise around career and education, fertility and family building, and many of these concepts that are important to all of our adolescents and young adults, and ultimately to give them the knowledge that they need to be able to advocate for themselves as they move into adult-focused survivorship care. We're doing this with a system of real-time process improvement with the assistance of one of our medical students, Alexander Jin, and all of this effort is funded by a Teen Cancer America program grant.
So let me leave you in the last few seconds with the idea that what we're moving towards is the concept of precision survivorship. We need to understand our problems. We need a descriptive phase, and then hopefully also that will lead us to design interventions. We're interested in the concept of survivorship for the lifetime and across the lifespan. And with that, we can open it up for Q&A. Steph, perhaps you can advance to our email so that if folks have, and thank you very much to all who make this work possible, please stay in touch with us, and we'd love to take your questions.
By the way, I answered one of the questions, but there's
Right.
two questions that that people have, and I think that either Steph or Lydia could answer this. What does this frailty look like in children and young adults?
Yeah, that's an excellent question. So in the study that I cited earlier, they really defined frailty using the standard definitions in research, and what they were looking at is muscle mass, looking at fatigue, looking at their physical responses to basically physical testing in the clinic. So I'm not sure if that gives you a sense, at least for that study. It was really a physiologically measured outcome that was also in combination, I believe, with report with respect to fatigue. Does that help answer that, Sam?
Yeah. I'll just jump in just quickly. So given the small numbers and the issues of population health, are there surrogate markers that could be helpful then that you might think about in terms of might be assessed earlier on, but rather than waiting longer or needing bigger population sizes?
I think that's an open and really important question that I think many folks in the survivorship community are trying to answer exactly with that idea. So to give you an example, for one of the outcomes that has been studied really for a long time is cardiomyopathy after childhood cancer treatment, right? Where we know that adults are at risk for early heart failure and decreasing systolic function, and that's been shown to be related in a dose-dependent way to anthracycline chemotherapy exposure. So that's one of those traditional exposures that we know a lot about. And a number of studies right now are investigating what are the biomarkers that you can identify cardiomyopathy early, and then ultimately, if you identify it, can you intervene to decrease that risk? And so I think there's a lot of really exciting work going on in that space, and certainly conversations that we should have around some of the newer therapies as well.
And to add to that, in the world of adult survivorship, there are quite a few investigators who are trying to identify what we call prehabilitation interventions. Right. So the idea of understanding what the common problems are after treatment or during treatment, and to begin this idea of rehabilitation as a way of preventing subsequent injury. And this is important in areas of preserving physical activity, muscle mass, nutrition, and some of our colleagues even on campus are interested in doing work in this area.
So there's one more question from Lisa Cheskin. What surveillance protocol is recommended for a childhood leukemia survivor in their adult life to ensure early detection of long-term effects of pediatric chemo treatment?
So
Another excellent question, yeah.
Absolutely. The best resource for adult survivors of childhood cancer, as well as childhood cancer survivors of childhood cancer, is through the Children's Oncology Group, the COG long-term follow-up guidelines, which are expert-vetted, really clinical practice guidelines that are exposure-based recommendations for late effects surveillance. And they can be found at www.survivorshipguidelines.org. Or just Googling or searching in your internet browser, late effects survivorship guidelines for childhood cancer survivors. So there's too many to go through right now, but what I can tell you is that they're very easy to use. They're widely used to implement survivorship care across the US. There's also international efforts to harmonize guideline recommendations between the US, Europe, and many other countries. And that's through a group called the International Guideline Harmonization Group, or IGHG. So that's another resource for late effects surveillance. Again, that's evidence-based.
Mm-hmm. There's another question. I'm not sure exactly who would like to answer this. The wide variability in routine monitoring across clinicians is particularly interesting. Would it be possible, perhaps in the next survey, to ask a couple of questions? One, roughly how many similar patients are they seeing each year? And two, what proportion of their practice does this represent? And three, do they recall having treated one or more patients with adverse outcomes? And if so, how long ago was this? I don't know who wants to answer this.
That's
I'm not a
For
clinician.
Steph. That's perfect for Steph.
Thank you. This is, do you see the question? Because there's three parts. There's,
I do. Yeah,
okay.
I have it open.
Okay.
So thank you for this question. I think this is specifically referring to the data that I presented from the CML Provider Practices Survey. So, so the details that I didn't explain were that these were pediatric oncologists who were asked to basically only fill out the survey if they treated patients with chronic myeloid leukemia or CML. I mentioned the information that more than 77% of them had been in practice for more than 10 years. What I didn't show you was actually the number of CML patients that they had treated with tyrosine kinase inhibitors was relatively low. And that really reflects our pediatric cancer experience nationally, I would say, which is that CML is rare in kids, especially compared to adults. And so I don't have the exact numbers in front of me, but the general, I would say, clinical practice experience in terms of patient volume of patients treated for CML with a TKI was relatively low, even though these were people who had been in practice for quite a number of years. The question of what proportion of their practice does this represent is an interesting one, the one that we didn't ask them, but would definitely be interesting in a follow-up setting. And similarly, in terms of their experience with actually having these long-term or late effects in their patients would be worth following up in the future. So thank you for those comments.
In the world of adult oncology, these are the kinds of problems we have often in trying to study rare cancers. Where it's really difficult to find people who have a lot of experience other than in centers of excellence. But in fact, these patients are cared for everywhere, so it's important to understand what care patterns are really available.
And for primary physicians who are taking care of these patients, how do they get the resources and the help or actually provide information to you? Will they be contacting you, Lidia?
Yes, that would be fine. It may be bewildering for primary care physicians to accept some of these patients. And that's why we're so interested here in building expertise in the primary care sector and having peers to refer to and having people who understand both the cancer treatment and also the primary care needs.
Right. And also because their data they provide you in the aggregate can actually be very helpful for future patients as well, right? In terms of, and also directing therapy.
that closes our concept for how to conduct this research. We want the questions coming sometimes also from those who are caring for these patients, so we can figure out what they need and design interventions to help.
Great.
Well, thank you so much for inviting us to come today, and I really appreciate everybody's questions.
And thanks very much for everyone who joined. Next, so I'll just thank the speakers, Melissa Bondy, Lidia Schapira, and Steph Smith. Please, their emails are here. Please reach out to them if you have questions or like to join their group. And I look forward to next month with Sunny and I talking about wellness. Thank you very much on January 11th. So thanks very much, speakers. And thanks very much for joining us.
Thank you.
Thank you.
Thank you.